Dr. Jennifer Johnson is our speaker today. As the president indicated, she is a C.S. Mott Endowed Professor of Public Health and Professor of OBGYN in the College of Human Medicine. She's actually was our first research hire in Flint. And she came to MSU from Brown University in 2015 to begin the division, now Department of Public Health in Flint. Her education began at Brigham Young University as an undergraduate in applied physics. She remained at Brigham Young and went on to earn her Ph.D. in clinical psychology. She then completed her residency at the Veterans Affairs Palo Alto healthcare system and later moved to Brown University, where she completed a postdoctoral fellowship and was on the faculty for 10 years. She's a licensed clinical psychologist, and she is really a leading national researcher in mental health and maternal health treatments and implementation scientist. She serves as the Chief Translation Officer for MSU's Office of Health Sciences, helping to guide the realization of the university's sustainable health strategic goals and to ensure uptake of research findings into practice and policy. Dr. Johnson has been the principal investigator of 18 NIH-funded research studies, worth bringing in more than $72 million, including her current 2 NIH center grants, the Maternal Health Multi-Level Intervention for Racial Equity Center at almost $19 million, and that's a partnership with Henry Ford investigators, and the National Center for Health and Justice Integration for Suicide Prevention in Incarcerated Populations. And again, that's $15 million grant, again, with Henry Ford partners. And you'll be hearing more about those today. Now, she doesn't stop there. She has 5 individual NIH grants that go along with that. I'm not sure when she sleeps. She is credited with the first large grant award received through the Henry Ford Partnership, the one I mentioned. And on a national level, she is the highest funded NIH researcher in any OBGYN department across the country. So her leadership at MSU includes serving on the MSU Strategic Planning Committee, participation in the Academic Fellows Program, and while also leading in her field through roles in national scientific boards, numerous NIH review committees, and prestigious editorial boards. Please welcome Dr. Jennifer Johnson.
Thank you so much for having me. If I can make the slides work. Okay. Suicide is a top 10 cause of death for people under age 65 in the United States. And there are effective interventions to prevent suicide. But the biggest problem in suicide prevention is how do we get these effective interventions to the people who need them at the moment they need them, especially those who aren't well connected with healthcare. So we do know some things about suicide risk factors, but these tell us more about who's at risk than when they're at risk. But let me tell you a story of someone we worked with. This man had been trying to rebuild his life. One day something went wrong and he lost his job and with it his hope for the future. He went home, his anxiety started to increase, and he started drinking. As he got more intoxicated, he started having suicidal thoughts, and he decided to end his life by crashing his car on the highway, making it appear an accident. But as he drove, he got pulled over by law enforcement. The police didn't realize that they were encountering someone in an active suicide attempt, and instead of being taken to the hospital, he was arrested and taken to jail. The criminal legal or criminal justice system in the U.S. is vast and wide and complicated and encompasses everything up on that slide. What a lot of people don't realize, I think, is that on any given day, most people who are criminal legal involved are actually in the community, even those who had previously been arrested. They're in the community, not in custody. Furthermore, jail's different from prison. People are usually in jail for only a few days. They often aren't convicted, and they may not even be charged. But part of what our research has found is that the fact of that criminal legal contact, that contact with the criminal legal system, like contact with the police or spending a night in jail, marks suicide risk in the community. Because if you're ever going to be arrested, it's usually at a moment when your life is spinning out of control, like the story I just told. And those interacting with criminal legal systems are especially likely to not be well connected to healthcare. So take a minute just to yourselves silently and guess what % of adults who die by suicide in the US spend at least one night in jail in the past year? Just guess. So our research has shown that 21% or more than 1 in 5 adults who die by suicide in the US each year have spent at least one night in jail in the past year. Therefore, this research has actually found an answer to the biggest problem in suicide prevention, which is how do you find people at risk when they're at risk, and especially those who aren't already well connected to healthcare systems. Our research has also identified evidence-based suicide prevention interventions for the 10 million admissions and discharges from jail each year. So that answers one big problem for suicide prevention. Unfortunately, there's a second big problem, as there often is. So the second big problem has plagued work with people returning to the community after jail, and again, typically brief, only a few days. But this problem has plagued us for 40 or 50 years. So the 3,000 jails across the US are city or local. They're independent of each other, and they just will never have the capacity to link people back to the community services that they need. And this is logistical. There's 10 million admissions, discharges a year. Like I said, typically only a few days. Discharges are unplanned, unscheduled. 2/3 of the people going through have mental health problems. 2/3 to 3/4 have addiction problems. The jails just aren't staffed to do it. It would be hard for anyone. And then on the healthcare side, the healthcare providers don't know their person was in jail and say, you're gone to jail for a week, you miss your appointment. Some of these systems will drop people from care for missing appointments. So then you might think, okay, well, maybe we can link all these systems electronically to let the health systems know their person has been in trouble. But it turns out, like I said up here on the slide, there's 3,000 county and local jails, 18,000 police departments, all these community health centers. All the data is in different formats. It's just not possible to electronically link all these systems, and the jails typically don't have good IT systems anyway. But as part of this work, I had a conversation with CareSource Managed Care Organization in Ohio. And I'm not sure if you know, but it turns out that arrest and release data out of jail are public, and health data is private. And it turns out that technology has advanced to the point that it's possible to scan this publicly available arrest and release data for matches to a healthcare system. So CareSource had realized that and was matching release data from the 108 Ohio jails against their own subscriber list each week. And making the connection this way is amazing. I was so excited when I realized someone was doing this because it doesn't require this release data to be in any particular format, doesn't require direct coordination with the jails. It protects the privacy of the health information, and it means that we have a scalable way to let local health systems know that one of their patients was just released from jail and maybe in crisis, and they might want to reach out and check up on the person. And like I said, this is a problem that's plagued us across health conditions for decades, addiction, mental health, infectious disease. So we put all these ideas and past work together that contact with the criminal legal system marks a high-risk time for suicide in the community, that we have discovered effective suicide prevention approaches, and that we now have a way to let the health systems know to reach out, solving these two huge problems simultaneously. So I got together with my colleague Brian Amadani at Henry Ford Health and my colleague Lauren Weinstock at Brown University, and we submitted a grant to the National Institutes of Health and were awarded a $15.5 million grant from them to create the National Center for Health and Justice Integration for Suicide Prevention. And what this center is, it's a set of 8 related research projects that demonstrate and test suicide prevention approaches based on these ideas. And one of the most important things about this is everything we're testing is pragmatic and scalable. So among these 8 studies are the 2 largest randomized suicide prevention trials ever. One randomizes 60,000 people and another randomizes 43,000 people. But the center is not only conducting important clinical research that saves lives, it's providing research training for junior faculty, postdocs, and students. We're providing training in suicide prevention best practices for health systems and criminal legal systems across the country. And this was, I believe, the first or one of the first major partnership grants of the MSU Henry Ford Partnership. This shows our first 4 projects. What's important here is less the details, but more to notice just that the projects take place across the country after police contacts, jail contacts, courts. And again, they're large and pragmatic, and what we're trying to show is how to get services to people who need them in a scalable way in the real world. So not surprisingly, this is a huge effort. We are collaborating with more than 15 different health system and university partners, and I'm especially excited about our long list of practice, policy, and lived experience partners. These are just a few up here on the right, but they include organizations of people with lived experience of suicide attempts, lived experience of criminal legal contact, prosecutors, sheriffs, judges, the American Foundation for Suicide Prevention, the American Jail Association, just a really fantastic group of partners that the center is bringing together to work across silos to try to prevent suicide for some of our nation's most vulnerable. So in conclusion, we have evidence-based suicide interventions in the community, and what this center does is demonstrate and test new ways to identify some of the folks most at risk in the community and connect them to these effective interventions to prevent suicide. Thank you.
Dr. Johnson, thank you so much for this exemplary work of public-private partnership between the university and all the partners that you've brought together. Thank you so much.
Oh, thank you.
I just have a comment. This is important work, in my opinion. It's revolutionary work. But Dr. Gage, you never disappoint. You always surprise me. So, and congratulations on all your grant work. That's a big deal. And I don't know how you're sleeping either. That's a lot. What I wanted to comment on is the way that you presented your data and your study. Your language was so careful. I pay attention to words a lot, and you didn't have any pathologizing. You didn't use carceral language. You didn't have any criminalization that you had ascribed to the participants in your study, the people that you are trying to care for. And it to me, the humanizing way that you spoke about the people that you're studying is a testament to your work, but also to the humanity that you're bringing through your research. And I just appreciate that.
Thank you so much. One of the things I find the hardest in this work is as soon as you say jail, people have 1,000 assumptions.
Yeah.
And as soon as you say suicide, people have 1,000 assumptions. Yeah. And so I've really worked with some of the wonderful MSU communication people to try to help people understand what this really is, because there's just a lot of assumptions in this. So thank you.
And you talked about people and folks and humans, right, and citizens and community members. This is your study, not the other ways that you can characterize them. And just that careful language was so important to me. I appreciate you.
Thank you.
Yeah, if I could comment. There's an aphorism that goes like this. I always wondered when someone was going to do something about that, and then I realized I was someone. And I've never met a person like you who, no matter the difficulty of the challenge, says it's hurting people and I've got to figure it out. And you could give a similar presentation of how you identified something that caused people to struggle and talk about how you analyzed it and how you could help. And so I just want to say just how fortunate we are at Michigan State to have you, and really the way that your life every day echoes to make other people's lives better. So thank you.
Thank you. I really, really appreciate that. I really thought, it's hard. This is such a public setting. We have 6 to 8 minutes. I thought, should I talk about my work with moms or something easier? But no, I really wanted you to understand this. So thank you for the opportunity to talk about it, even though it's tough.
Thank you very much.